Hello everyone, I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this session, I will be discussing the diseases of the posterior pituitary. So please remember, posterior pituitary will only act as the storage organs of the hormones. And the hormones which are being stored within the posterior pituitary are oxytocin and as well as the vasopressin. And this particular vasopressin, it is also called as the antidiuretic hormone. So if you see this point, what are the posterior pituitary hormones? As such, posterior pituitary does not synthesize the hormones. It only acts as a storage organ and it will secrete the hormones. Then, where are these posterior pituitary hormones synthesized? Posterior pituitary hormones, please remember, they are synthesized within the hypothalamus. Right? We have two important nuclei within the hypothalamus. One is the supraoptic and the other one is the paraventricular nuclei. So the supraoptic and as well as paraventricular nuclei in the hypothalamus, they secrete this vasopressin and as well as the oxytocin. And you have to remember that these particular hormones from supraoptic and paraventricular nuclei, they are transported to the posterior pituitary lobe via hypothalamo-hypophyseal tract. And depending upon the requirement, they are being released from the posterior pituitary gland. So this is a very important point that you have to understand. Now, if you see the abnormalities associated with the antidiuretic hormone. Antidiuretic hormone, this is also called as vasopressin. And why is it called as antidiuretic hormone? Because it will prevent the diuresis by acting at the distal tubules of the kidney. Then why is it called vasopressin? Because it will cause vasoconstriction, and that is the reason why it is called vasopressin. Now, the abnormalities associated with the antidiuretic hormone is that the individual will end up in what is called diabetes insipidus. Right? The individual will end up in what is called diabetes insipidus. Now, what is this diabetes insipidus? It is a disorder where either partial or complete absence of the antidiuretic hormone. That is one abnormality of the antidiuretic hormone. And another abnormality of the antidiuretic hormone is the excessive production of the antidiuretic hormone. And that excessive production of antidiuretic hormone, we call that as syndrome of inappropriate antidiuretic hormone. So these are the two important abnormalities related to your antidiuretic hormone that you have to remember. Next, followed by that, at what age does the diabetes insipidus occurs or the diabetes insipidus starts? So please remember that diabetes insipidus, it starts in childhood or in early adult life. And the other very important point is that this diabetes insipidus, it is more common in men rather than women. This is another very important point. And the next point is that we have two forms of diabetes insipidus. One is central diabetes insipidus and the other one is nephrogenic diabetes insipidus. Now let me tell you what is central diabetes insipidus. It is a disorder where there is partial or complete absence of the antidiuretic hormone. Right? It is a disorder where there is partial or total deficiency of the antidiuretic hormone. That is what is called as the central diabetes insipidus. Then followed by that, what are the features of the central diabetes insipidus? Right? What are the features of central diabetes insipidus? So antidiuretic hormone is the one which is required for the reabsorption of water from the distal tubules of the kidney. So when your antidiuretic hormone is absent, what will happen? The water gets excreted out in the form of urine in excess quantity, and that will result in the individual to develop polyuria, right? So there will be excessive dilute urine, right? There will be excessive dilute urine that is passed out. And what will happen to the serum osmolarity when excess amount of urine is excreted out? The serum osmolarity is increased, and that is the reason why the individual will have increased thirst. Because once there is increased serum osmolarity, that will go and stimulate the thirst center in the hypothalamus, and thereby the individual will have increased thirst. And these individuals, they have hypernatremia. And why is that? Because in patients with central diabetes insipidus, there is free water excretion in the form of polyuria, and the sodium, it remains within the plasma, wherein the individual will develop hypernatremia. And if you take the normal sodium levels, they are around 135, right? The normal sodium levels, they are 135 to 145 milliequivalents per liter. And in case of hypernatremia, the sodium levels will be more than 150 milliequivalents per liter. So these are the features of the central diabetes insipidus. Then followed by that, what is the etiology of central diabetes insipidus? So the etiology include either the pathology should be in the hypothalamus or the pathology should be within the pituitary gland. So if you see the pathology in the hypothalamus, what are those pathologies? That includes neoplastic or the infiltrative lesion of the hypothalamus, or the pathology should be in the pituitary gland where there is partial or complete loss of the anterior pituitary function. So that is what is the etiology of central diabetes insipidus, right? Then there are certain lesions in the hypothalamus and as well as the pituitary gland which will predispose the individual to develop central diabetes insipidus. Now, what are those lesions? These particular lesions, if you see the lesions within the hypothalamus, that includes secondary to your adenoma and as well as the craniopharyngioma. So craniopharyngioma, it is a tumor. Then if you take the lesions within the pituitary gland, that includes the pituitary adenoma, then leukemia or sarcoid histiocytosis. These are the one which can lead to the development of diabetes insipidus. So these are the lesions which can lead to the development of diabetes insipidus, right? Then what are other causes of central diabetes insipidus apart from hypothalamic and pituitary lesions? Those include, number one, surgical lesions, right? You have done completely pituitary adenectomy, then in such case there will be deficiency of antidiuretic hormone. The same way the hypothalamic surgery. Then radiotherapy to certain tumors can hit the pituitary gland or the hypothalamus, severe head injuries, then anoxia, right, or the anoxic insult to the brain, hypertension and meningitis, and these are the etiologies which will cause central diabetes insipidus. So to summarize, the pathology should be either in the hypothalamus or within the pituitary gland for the development of the central diabetes insipidus. Then followed by that, there are also certain infections that will cause the central diabetes insipidus. And you need to know that very important infection is the syphilis and as well as the tuberculosis that can affect the pituitary gland and then make the individual to have deficiency of the antidiuretic hormone, resulting in central diabetes insipidus. Then what do you understand by this word nephrogenic diabetes insipidus? Nephrogenic diabetes insipidus is that where there is resistance to the antidiuretic hormone at the level of the distal tubules. That is what you mean by the word the nephrogenic diabetes insipidus. So it is the disorder where you have renal resistance to the action of vasopressin. That is what is called nephrogenic diabetes insipidus. Now, what are the etiologies which will cause nephrogenic diabetes insipidus? We have certain drugs, right? We have infiltrative pathologies causing nephrogenic diabetes insipidus, right? And let me discuss all those. Okay, so it can be idiopathic or it can be secondary to hypercalcemia. So we have a clinical entity called nephrocalcinosis where whenever the individual has excess calcium, normal calcium levels are 9 to 11 milligrams per deciliter. And when the calcium level is more than 11, it can go and get deposited within the kidney wherein there will be resistance to the action of antidiuretic hormone to show its action. So there is one etiology, that is hypercalcemia. Then hypokalemia. See, whenever there is hypokalemia, the tubular function of reabsorption of water gets reduced. Why? Because there is resistance to the action of the antidiuretic hormone. The tubular function will not work properly. So hypokalemia is another cause for nephrogenic diabetes insipidus. Sickle cell anemia, amyloidosis, multiple myeloma, pyelonephritis, sarcoidosis or the Sjogren syndrome. So these are all the causes of the nephrogenic diabetes insipidus. You take in case of amyloidosis or in case of multiple myeloma, it is the abnormal protein which gets accumulated within the distal tubules, and because of the accumulation of the abnormal protein within the distal tubules, they become resistant to the action of antidiuretic hormone, and that will result in the development of what is called nephrogenic diabetes insipidus. And the same way is your pyelonephritis, where the infection of the tubules will make the individual to have resistance to the action of antidiuretic hormone. And in sarcoidosis, there will be accumulation of non-caseating granuloma within the kidney. And Sjogren syndrome, where you have the autoantibodies which will be destroying the function of the renal tubules for the action of antidiuretic hormone. So these are the causes of the nephrogenic diabetes insipidus. Then, what are the drugs which will cause nephrogenic diabetes insipidus? The drugs causing nephrogenic diabetes insipidus include lithium, right, which is used in the treatment of bipolar disorders, demiclocycline, which is an antibiotic, that is a tetracycline, colchicine, it's an anti-inflammatory drug which is used in the treatment of pain. They can cause nephrogenic diabetes insipidus. Now, what are the clinical findings of nephrogenic diabetes insipidus? Right, it is more or less same to that of your central diabetes insipidus. What is that? There will be excessive excretion of water in the form of urine. So there will be polyuria. Right, there will be polyuria. Now you should also know, when do we use this word polyuria? When the individual excretes more than 3 liters per 24 hours, then we use this word called as the polyuria. Right, and other important clinical manifestations include excessive thirst. Now, what are the investigations in patients with the diabetes insipidus? So if you see the investigations, they will have hypernatremia. I have also explained you the reason. The reason is that there will be free water excretion and the sodium will retain back, resulting in hypernatremia. And what will happen to the serum osmolarity? The serum osmolarity is also increased. Why? Because excess amount of water is getting excreted out in the form of urine. So serum osmolarity increases. And subsequently, what will happen to your urine osmolality? Urine osmolality will be reduced and urine specific gravity also will be reduced. Why? Because there is excess amount of water in the urine. So these are the baseline investigations in diabetes insipidus. And how do you confirm the diagnosis of diabetes insipidus? The confirmation of diagnosis of diabetes insipidus, it is done by what is called as the water deprivation test. See, in case of water deprivation test, what is that you will do is, you will compare the urine osmolality after dehydration versus urine osmolality after vasopressin supplementation. Right? You will compare the urine osmolality after dehydration versus urine osmolality after vasopressin. Now, what is the response of the water deprivation test in a normal individual? In a normal individual, whenever you do a water deprivation, what will happen? That in water deprivation, what is that you are doing? You are restricting the fluid intake. So thereby, what will happen to the urine volume? That is decreased. And thereby, what will happen to the urine osmolality? That will be increased. So this will be the response of water deprivation in a normal person. Then, what will be the response of the fluid restriction in a diabetes insipidus patient? Now again, it all depends whether it is central diabetes insipidus or whether it is nephrogenic diabetes insipidus. Whatever it is, in spite of fluid restriction in diabetes insipidus patient, there is increased quantity of the urine. The urine volume, it remains increased despite volume depletion. Right, despite volume depletion. And ADH will be decreased in central diabetes insipidus, and the quantity of the ADH will be increased in nephrogenic diabetes insipidus. Why? Because in nephrogenic diabetes insipidus, it is not the problem at the level of your hypothalamus or pituitary. The problem is at the level of the distal tubules. So the distal tubules, they are resistant to the action of the antidiuretic hormone. So the hypothalamus or the pituitary, they feel that there is no ADH, and that is the reason why the water is not being retained. So that is the reason why ADH is excessively secreted from the posterior pituitary in nephrogenic diabetes insipidus. Then what will be the response in diabetes insipidus patient whenever you do a fluid restriction? So if a patient, okay, I'll just show you a graph here, right? That graph will explain you, okay? Now, see, this is in a normal individual, right? This green line is in a normal individual. Whenever you do a water deprivation, what will happen? The urine volume decreases and serum osmolality increases. That is what will happen whenever you do a water restriction in a normal individual. But you take in patients with the central diabetes insipidus, right? You take in patients with central diabetes insipidus. Whenever you give antidiuretic hormone, that is the point when the urine volume, it start decreasing. But whenever you give antidiuretic hormone, there is no response in case of nephrogenic diabetes insipidus patient. So in spite of doing water deprivation and in spite of giving the antidiuretic hormone, in patients with nephrogenic diabetes insipidus, there is excessive water excretion. So in summary, in central diabetes insipidus, when you give ADH, the urine excretion decreases. But even though you give ADH, in patients with nephrogenic diabetes insipidus, the urine excretion does not decrease. So that is the summary. Okay. And investigation of choice is water deprivation test. Then followed by that, what are the differential diagnosis of diabetes insipidus? The very important differential diagnosis of diabetes insipidus is the psychogenic polydipsia. See, in patients with psychogenic polydipsia, what happens is the individual will try to consume excess amount of water, right? The individual will try to consume the excess amount of water because of some psychological disorder. So that is the reason why the individual will also be excreting excess amount of urine as well in patients with psychogenic polydipsia. So in patients with psychogenic polydipsia, for suppose if you do a water deprivation, what will happen is the urine osmolality increases and urine volume decreases. Right, that is what will happen in psychogenic polydipsia. But what is that we have discussed in diabetes insipidus? In spite of doing water deprivation, the urine volume will be on the higher side. Okay, so the very important differential diagnosis of diabetes insipidus is psychogenic polydipsia. Then, how do you treat these patients with central diabetes insipidus and nephrogenic diabetes insipidus? So, you should know what is the treatment of central diabetes insipidus. The treatment of central diabetes insipidus is that you need to give vasopressin analogs. And what is the example of your vasopressin analogs? That includes the desmopressin. Right, that includes desmopressin. And this particular desmopressin, it is given either subcutaneously, or it is given orally, or it is given intranasally. So these are the various vasopressin analogs. Right, and the example is desmopressin. Next, what are the drugs that stimulate the secretion of the antidiuretic hormone? See, we have three important drugs. One is your chlorpromazine. One is your chlorpropamide, that is a first generation sulfonylurea. Then clofebrate, which is used in the treatment of dyslipidemia. Carbamazepine, which is used as an anti-epileptic drug. These drugs, they increase the release of the antidiuretic hormone. Then